At the outset, I would like to congratulate Dr. A.K. Singh. मैंने डॉक्टर A.K. सिंह की बड़ी तारीफ सुनी है वीडियो में से। मेरी महान प्रवीण ने मैं कार्डियोलॉजी में तो बहुत अच्छा आपने किया। I think he has really done the pieces of acute edema. They can be saved by the use of non-invasive devices. Our hypotensive. In that situation, this extent will be the role of non-invasive ventilator to save these patients. After that, we can give dialysis or whatever you want. Thank you very much, Dr. Singh.
In a month, I am average on a forum speaker 6 to 8 is every month. But really, when I am in front of our teachers, I am a little bit nervous, but I am trying to justify my talk. Topic given to me is hypertension and its arrhythmogenic complications. When I did my PG 98 to 2001, on that time we was managing the hypertension. And when we are dealing for the hypertensive heart disease, SC was going LVH, concentric hypertrophy of left ventricle. And with ECG, we was calculating left atrial overload. And somehow this Morris index and so that not meeting 100%. So I was the first one. Sir sent me to establish Eco Lab in Jhansi to AIIMS New Delhi, and I established in 2000 with HP Sono 2000 machines. So when we are dealing with the hypertension is not a just number, disease of magic number. When this should be in our mind, we should think of its complication. Suppose two patients came to us. One patient BP was 180 by 110 and one patient BP was 140 by 100, and we investigate the patient. 180 by 100 it is good, ECG कोई कमी normal, just diastolic dysfunction, no cardiomyopathy is something. But 140 by 100 on the same time, this practically happened to me. We have done the echo, and echo, there is era when you are thinking for this hypertension, please make focus on left atrial myopathy. Don't jump on the left ventricular hypertrophy. That's very important. And diastolic heart failure, when you are telling HFpEF, hypertension is 40 to 50% of causes. So left atrial myopathy is very important because hypertension, when you are telling LVH is the late complication. Just before Dr. Saxena was here, and he mentioned that palliative pulmonary vein ablation is doing 8 to 10% of cases while AVNRT patient, for recurrent AVNRT patients. So what happened, why there is arrhythmogenic potential? Hypertension can cause any type of arrhythmia. Ventricular ectopic, couplet, triplet, tachycardia, and supraventricular ectopic. Supraventricular, any type of ectopics. AVNRT, AVRT, atrial fibrillation, some ectopic rhythm, but today I am focusing on this atrial fibrillation. We know that hypertensive patient, lone atrial fibrillation, it is important cause around 20-25% of cases. You see the different literature, and that's why this is one indication Dr. Saxena was telling. If you are having patient of concentric hypertrophy of left ventricle, high and feeling pressure, left atrial myopathy, this is one indication. If possible, send the patient to have a CMR also to see the vasculature. That's a very important way. Anyway, why atrial fibrillation is there in a hypertensive patient? I am raising this point. So if we discuss for the pathogenesis of hypertension in atrial fibrillation, starting from the left atrium, what happened? Left atrial myopathy, some inflammatory process is going on, some mechanistic problem, some electrical problem, and difficulty in calcium handling, and this pathway problem. So this all, we know we are dealing with the BNP in our practice, but we are not dealing with the ANP, atrial natriuretic peptide is also there, and that is a very important biomarker for development of atrial fibrillation in the futures. That might be doing in the institute somewhere. But when you are talking for this atrial fibrillation, prevention of atrial fibrillation, primary prevention. Once we have in the ECG atrial fibrillation, we will go to calculate Church-Weiss score and start some NOAC or something. Okay. Important is how to predict atrial fibrillation. I am not going for the AI generated. I am telling for the clinically. That is the more important in our clinical practice. If in my patient is diabetic hypertension, CKD, creatinine 1.1 to 2, and I have seen LA is dilated and somehow there is LVH, LV masses high. So I will be very cautious and vigilant for this patient that in future this is notorious candidate for the development of atrial fibrillation. So my intention when definitely when you have the atrial fibrillation, you will send the patient for the echo. Forget ejection fraction. Focus on the left atrial morphology, and my dear friend Ram Babu may be here. Maybe I am here doing 100 ego daily. So you see 3-4 things in the atrial that are important. What is size of atrium? What the filling pressure, what we are calling E by E prime, very important for development of ectopic foci, PCWP and LA index volume. That should be more, usually 34, 35 like this. And beyond this, LA will be dilated when there is a consistently chronic pressure overload. But what happens in acute condition, if you are doing strain imaging, just calculate LA reservoir strain. We are doing in my practice. If strain rate is reduced, this is a notorious candidate in the future for the development of atrial fibrillation. With this background, I am starting my presentation. That hypertension, we know this is an important cause for this all kind of condition, starting from a severe heart failure, CAD, CCF, and hypertension. When we are telling CAD and CCF, don't think for this only obstructive CAD. When I am talking for this hypertension, okay, this atherosclerotic problem is going on, but usually what happens in a hypertensive patient coming towards a shortness of breath and chest pain like that, syndrome like angina, and when you are getting the ECGs having some changes, TMT might positive. Echo doing this, having some changes, high filling pressure and LVH. TMT might positive, but खेल यहाँ शुरू होता है. When sending the patient to intervention and angio done, nearly normal 3 epicardial coronary arteries. Then what to next? Patient is telling doctor, फिर मुझे angina की दवा क्यों लिख रहे हो? Okay, I was having shortness of breath and chest pain. So there is a microvasculature in the hypertensive patient. In epicardial coronary, we are looking only 3 major arteries. We are not looking at epicardial coronary arteries, and that is a very important source for the development of ischemia. And one of the very important intervention cardiologists, I remember before 2-3 years in the Ahmedabad, treat the ischemia, not the obstruction. So ischemia treatment is important rather than the only obstruction. So coming to this hypertension, important risk factor for the development of all kind of these problems. LVH, that is the important way for the development of supraventricular and ventricular arrhythmia. Different medicine we are using that may cause electrolyte imbalance, and that is a potential source for the development of atrial fibrillation. That should be remembered. So preventive measures should be taken always, and this is some how this develop this hypertensive patient. We know all these axis, ROS axis, sympathetic nervous system, and this is a hyperactive. This heart rate is high, and because of fibrosis, things is going on. So there is some changes. Initially, we are looking for the ECG, and then subsequently came EQ and coming to era of this CMR. So what we are looking for this in this, some electrical changes there, some change sympathetic nervous system loss activation there, some electrical changes is going on, and at the cellular level, just I can tell you more technical EAD, DAD. But what is the importance? Because of chaotic activity, chaotic effective refractory period is reduced of the atrium, and that atria become more chaotic. That is more important. And this in turns ECG causes shortening of PR interval, left atrial overload, QRS widening, and QT prolongation. That is the one important thing. There should be, if you are going beyond this level, and when there start a cellular myocyte hypertrophy, then ECM expression. So some changes in the echo started, and this is the important thing: increase LA size, LV mass, and reduce LA and LV strain. Usually maybe here also you are looking with the GLS strain, LV strain. But LA strain is a very important, and there is one article, sir, in 2023, this published in the JAC, Journal of American College of Cardiology. LA strain should be must or routine. When we are evaluating for this patient of this heart failure or HFpEF, so there might in future recommendation came that LA strain calculation is important when we are dealing with a hypertensive patient and defining the atrial morphology. So, uncontrolled hypertension is an important risk factor. This causes some anatomical changes and some remodeling in the atria and the ventricle. This carry poor prognosis. Hypertension independent risk factor for the thromboembolic complication. We know this causes severe important cause and important even in my practice also and everywhere. When we are getting the hypertensive patient, how many years are going to calculate their ASCVD risk score, risk model, charts wise score also. So this is important. So our brain will wake up for that. In future, this patient is going to develop this kind of calculation. Anyway, patient is in the atrial fibrillation, you calculate charts, you know charts as score, having some history of cardiovascular problem, hypertension, AIDS, diabetes, and some vascular disease. And sometimes if you are going for a NOAC or VK, usually we are using NOAC right nowadays. So you should calculate has bleed score also, that is important. So hypertension lead to some kind of changes. If you will be adequate control of blood pressure is there, crucial to improve the AF outcome. Hypertension patient may promote cardioembolic stroke. Endocardial thrombogenesis is the very important. We know if we are maintaining the integrity and health of vascular tree, we are telling right now that diabetes hypertension is not a disease of blood sugar and magic number. It is a vascular problem. तो जितना हो सके हमें एक्सिस पे ही झांकना है rather than to see the grossly what is going on and how to see vascular very simple, just to see some premature marker of atherosclerosis, that is very important. Just to see intima-metal thickness, ankle brachial HSCRP, patient is not acutely sick, and you can make some little how patient is going to behave in the futures. Then coming to primary prevention, once a disease atrial fibrillation develop, then okay, there is a guideline. You go for this, no. How to, first idea is to go and control the blood pressure adequately. And there is one blanket instrument, RAS and ACE is the better molecule for complication and reduction of LVH and heart related complications as compared to other. I am not going to detail one by one. As compared to calcium channel blocker, alpha blocker, central and so and so. And having some different in their potential also, some differentiated misartan or misartan, losartan also. So RAS blocker has shown to partial reversibility of the LVH, improve electrical and structural parameter to reduce the AF burden. So here we are controlling this blood pressure tightly. Losartan associated better reduction in AF episode and the better overall outcome as compared that was in the life study. ASARB had a better role for preventing AF occurrence in presence of LVH and systolic heart failure. So RAS blocker demonstrated a lower risk of AF development as compared to calcium antagonist. While you are treating the hypertensive in your armamentarium for the treatment prescription, there is no genuine contraindication. Might AS and ARB is the good option for the primary prevention. So RAS blocker showed a net superiority over the beta blockers, but make sure this is for the regression of LVH. But once you LVH, atrial fibrillation is established. And one thing regarding the beta blocker, I will say hypertension is product of what? You need to reduce the cardiac output and afterload and cardiac output reduction, the stroke volume and heart rate. So how is it possible without reducing the heart rate you will control the blood pressure? What we are doing with the medicine, we are reducing preload, we are reducing afterload, and so heart rate reduction is also important. And we cannot become very, I say this word in front of that European also, we cannot become puppet of anyone. If they say that beta blocker should be in a specific situation, in heart failure, in atrial fibrillation, if my patient is my property and in front of me, I have seen it, heart rate is 120. and having all this sign of target organ damage, maybe still so until I am not going to reduce. And inter-heart study, sir, is here. No, sympathetic overactivity was around this 50 to 60% of cases. So when we are dealing with the my patient, we should decide what is. So beta blocker is in my practice, even the cardiology practice, a very important option even to control the blood pressure, and we are using it. Not just going for this ABCD. There is the Indian Society of Hypertension. There is a guideline also, and I am their joint national secretary. Their guideline also came, and all these guidelines they mention ECG. When sir, its discussion was going, we were three. Luckily, I was one. Dr. M. K. Das from Kolkata, Dr. Aditya Kapoor from PGI, and I was one. We was connected online, and in Indian Society of Hypertension, we gave the advocacy that echo should be must done. And I was one say, sir, if you are telling this vascular problem from day one you go reduce, how to calculate your filling pressure, how to mention the LS size, ECG, what you tells in diabetic hypertensive patient. So in the guideline of Indian Society of Hypertension, echocardiography is supposed to be an important tool of investigation from the day one. You can read it, it is available online also. Now coming to important aspect, this atrial fibrillation usually associated with the primary hyperaldosteronism. Dr. Sankar sir is here, and I remember when he asked me a question for the primary hyperaldosteronism when I was JR3. So make one thing always, when you are dealing with a hypertensive patient and once it is becoming resistant or refractory, in spite of giving all 3-4 medicines, optimal, supraoptimal doses with optimal dose of diuretics, if BP is not going to control well, your eyes should be immediately open to think of primary hyperaldosteronism, and very simple investigation just to see their potassium level. If it is coming persistent hypokalemia, ask for plasma renin activity. You can find out the clue. Please, I am requesting, don't ask anything you. This tea and coffee serving people. And okay, if it is clue is there, you go and see the plasma aldosterone level. If it is more than 10-15, diagnosis is confirmatory. But as a clinician, important is your hypertension is resistant and refractory, and you are going to giving medicine. That is very important. And if your diagnosis is primary hyperaldosteronism, that is a very strong association with atrial fibrillation. So optimization of here the MRA is the important. Just keeping in the mind that what is serum potassium level. So primary hyperaldosteronism, as mentioned, important cause. Its diagnosis, there is an algorithm. If BP is persisting, not going to control well, and is even a younger age, it is more than 140/100, then you should be cautious, and spontaneous going for this spontaneous diuretic or induced hypokalemia, adrenal incidentaloma, and history of AF, family history of AF, and some high risk. So you should, in this kind of patient, you should be screened for a primary hyperaldosteronism. As I mentioned, if it is somehow 10 to 15 positive, more than 15, the test is confirmatory. So one thing, AF patient, you should be screened if BP is not controlled. Two conditions: AF, primary aldosteronism, resistant and refractory hypertension. Primary hyperaldosteronism should be ruled out. That should be important. This is the algorithm for the workout. No need to go in the detailed algorithm, but important is hypokalemia, plasma renin activity. This should be always in the practice. So early detection of atrial fibrillation is the important. As I mentioned, you go and see the clinically, not always ECG. Our teacher teaches what the clinical sign, and see the pulse and this pulse delay and so on. So fibrillation, flutter, anything can be happen, and life-threatening thromboembolism can be happen. So ECG monitoring devices and that is the importance. So this is the flow chart. Some hypertensive patient come with us. with some history of stroke. Now, things is clear, you go for the NOAC. Calculate child stress score. If more than 2, you go for the NOAC. If no, then what to do? Then see if hypertensive patient have some implantable devices, then again you go and start NOAC. That's very important. If no, then you start again the clinical sense. You take the history, what is your age, or 65, high risk patient, and past history. On the same time, you see the ECG criteria and NATO criteria, as I mentioned, prolongation of peer interval, Morris index, broadening of QR amplitude interval, and wide QRS complexes. Echo criteria, you see the LA index volume, filling pressure, PCWP, strain, GLS, and this all you calculated. Then what next? There is possibility that my patient will be develop AF or not to be developed. If develop AF, then it is good. Something is coming and you plan for this NOAC in future. Or if the patient is having some interactive devices, then you use this NOAC. The issue is coming how to screen the AF, that is the important. So this mentioned in this downwards. There's so many devices is there, some smart watches. That's important for technician is clinician and technician everywhere is this clinical examination, that is we see this irregular pulse and some pulse deficit. There's a smart watch is there. And important is Holter monitoring, and if not only 24 hour if needed, you can go for the more than 24 hour Holter monitoring, so abnormal events also. Even you can detect ectopic also, ventricular ectopic with this. So if atrial fibrillation, okay, start NOAC. If no, then you should be go for this and plan for this patient that it is notorious candidate for the development of atrial fibrillation. This is the same pathway. Screening of AF is the important, and clinical sign is the important. And if you need it, you go for this Holter monitoring also. So this is the proposed algorithm and for the arrhythmia with the hypertension. And as I mentioned, this should depend on so many factors. So the proposal for the standardized initial workup in the patient, the arrhythmia and the hypertension, depending on the duration, the severity of symptoms, frequency of episode, and potential therapeutic implications. As I mentioned, supraventricular arrhythmia may be other type, AVNRT, AVRT also. So you detect it. While detecting, we know the EC is the important tool, but my previous speaker is mentioned is we go for the Holter monitoring. If Holter 24 is not going to pick up, we go for the 72 hour ELR for the complete 7 days. If it and you pick and you start the treatment accordingly. Either a discussion was going on aldirism or verapamil or whatever you needs. Only few cases of the atrial fibrillation, that are very rarely that maybe need some biopsy, and risk management should be calculated. And in this condition, if LVEF is a very poor, and if you are dealing with the atrial fibrillation with some ventricular ectopic and some possibility of the development of this VTEC and this kind of things is there, so you should be think of these implantable devices in this kind of patients also. One things is coming, when I was doing PG, there was no NOAC. So we are using VK when we use it. But right now we have VK and NOAC also, but VK have the limited use, we are using in this especially mechanical prosthesis VK, except in diabetic mild to moderate position, VK using. The problem is this labile INR and TTR, the difficulties. Anyway, if you want to, this is one score, calculates MBT2 or 2 scores. If your score is less than 2, you can go for the VK, and if it more than 2, you can go for the NOAC. When you are dealing hypertensive atrial fibrillation and this is non-valvular, we stuck on this NOAC, and NOAC depend on their different parameter, renal parameter, their pharmacokinetics and time. That is not my part of discussion today, but NOAC is the better option. So, if you are not treating any disease well, economic burden is always there. So, Cost is the important concern. If you have calculated the hypertension well, so we are going to reduce the major cardiovascular disease and their events by 20%. We reduce the risk of CAD by 17%. This mentions obstructive CAD and non-obstructive also. INOCA and MINOCA is the important hypertension, the important cause. Risk of stroke reduced by 20% and HF by 28% and all cause mortality reduced by. This is some magic number. I mean, but what I believe. No need to become confused in a magic number. Need to believe more and more in the pathophysiology of disease. That is the more important. Because practicing in the Lucknow, interacting with the so many type of doctor, even tertiary care center also. So treatment of the patient and justifying their symptom and relief is also important. So many patients coming to me with that exactly, again I am repeating, with a symptom of ischemia like ischemic syndrome, and they are still having shortness of breath and not giving anti-anginal medicine. Practically I am giving metabolic modulator, that kind of medicine, and they are doing very well, they are happy, the ischemic symptom improved. So this is important. So conclusion, is a long but enhanced RAS and pathophysiological mechanisms in hypertension contribute to development of cardiac arrhythmia. That the important SNS is the one important cause. Primary prevention is the important way to reduce this AF burden, and how to control the BP wave, control with the right molecule, and think of since day one what the condition of respiratory and what the chamber status of heart, their atria and ventricles, and patient-tailored approach, pathophysiology driven strategy necessary to including use of RAS inhibitor in essential hypertension and early detection of secondary hypertension caused by disease. Anyway, no need, you stop it. I will finish it. So if I am finishing my words, this diabetes and hypertension don't treat like a magic number disease and magic sugar number disease. This disease started the vascular problem and is affecting the vascular tree. So thank you. I left some time for comments and questions. Welcome to Conference of Hypertension, Asia Pacific Conference of Hypertension. Me as a Rai Secretary, inviting you there. It is available online, registration and everything. So welcome for this conference. Thank you.
Thank you. Thank you. The source of atrial fibrillation on Fitbit with no other associated risk factors. And her ECG echo was done and Holter monitoring was done. It was all normal. So what do you recommend for such patients?
Good question, but you complete your question. Not young. Tell me exact age and what the risk factor.
28 years old.
28 years. Any other risk factor?
No appreciable risk factors.
No appreciable risk factor, and 2 episodes of atrial fibrillation.
Documented on Fitbit.
This is documented, and
yeah.
No definite risk factor.
And she's a medical student.
And family history also.
Not really.
Not significant.
Yeah.
So and you are telling echo is normal. Echo normal is no ejection fraction normal. Again, I am emphasizing.
I mean, majority of this thing was all normal. Nothing was picked up for that.
So in this condition, we will not go for the NOAC. We will wait and watch because there is no risk factor. This episodic atrial fibrillation, just 28-year-old female. So a cause of atrial fibrillation is not just everyone is organic cause. This is psychological stress and emotion type of tachycardia, this can be happen. So if there is no risk factor, family history, personal history, and echo I am emphasizing, not loving ejection fraction. If their feeling pressure is normal, their E by E prime is normal, PCWP is normal, LS size is normal, index volume is normal, and strain rate is normal, then I will not treat the AF in this patient. I will keep monitoring for this patient. Monitoring is the broad term. I will keep monitoring maybe 3 to 6 months for this patient. And what should be future, let us decide. But initially, this will be my plan. Sir is here.
Also, I would like to make one comment, maybe tachycardia, and you would not bother to start with ACE inhibitors and you would simply go away with beta blockers. So what I do in
No,
such...
this was not, maybe you are not listening. What I told, we reduce afterload and we reduce heart rate. But majority of guideline what mention? Beta blocker mention, even the ESC latest guideline, beta blocker used in the specific condition if it is associated with thyrotoxicosis, patient having atrial fibrillation and heart failure, cardioselective beta blocker. What I told, if I am treating my patient and my patient tachycardia is there, so how is it possible I will control with the AS and ARB and a calcium channel blocker? So beta blocker is the mandatory. This was the my statement, not only with the beta blocker. You add in your cocktail beta blocker to reduce the heart rate. This was my statement.
And one...
atrial fibrillation is the commonest of them, but otherwise also by causing ventricular hypertrophy it can cause ectopic beats and all. And with progressive diastolic dysfunction, there may be left atrial dysfunction also that further contributes to atrial premature beats or atrial fibrillation. So arrhythmias are common, but the primary, as he rightly pointed out, first thing is to control hypertension. Don't allow hypertension to reach a stage where it produces ventricular hypertrophy or atrial strain. So that is of course the best thing to do. Otherwise the arrhythmias should be managed as they occur in everybody else. But controlling blood pressure is very important. And I agree with that point that whenever we find that patient has sympathetic overactivity in hypertension, we must give beta blockers.
Dr. P wave in V1, this is known as left atrial force. If the multiplication of depth and width of P wave is more than 0.04 millimeters second, so this indicates left atrial enlargement. So width and depth of P wave in V1, if this is the multiplication is known as left atrial force. So if that is more than 0.04 millimeters second, so that indicates left atrial enlargement.
Thanks.
Calculation of AF risk. Strain imaging.
Strain imaging you are asking, boss.
In the class.
Thank you. He is my senior. He was my registrar during my first year.
Calculation of AF risk.
Yes, AF risk. I am coming on that. So GLS we are doing routinely, but when we are calculating the LA strain, problem is in the cardiac cycle, you know, this rapid filling phase and period of diastasis and the booster to the pulmonary. In the same way, we need to calculate three strain: reservoir strain, then pump strain, and then booster strain. So in the three strain calculation, and this usually is 8 to 10 minutes. But recommendation is if you are having patient of this hypertension with LA dilation somewhere and you are suspecting left atrial myopathy, that's why I quoted this 2023 papers. So LA, especially reservoir strain, this normal value is up to 35 to 40. If left atrial myopathy is what, you know, this volume changes is a chronic process. Suppose it was 40, you are giving the medicine, it will become 38 after giving SGLT2 diazepam, and so it is 3 to 6 months. What showed in the Empira reduce and this with the empagliflozin. But when you are calculating the strain and it acutely raise and you are giving the proper medicine, so that acute changes, the pressure changes in the strain changes. So you can pick up early changes how is left atrial behaving. So yes, if strain is reducing, this is a risk factor for development of atrial fibrillation. My senior Dr. Saxena is also here. He can comment on this, and this is a given that. Yes. Yeah. Evaluation of AF risk, atrial fibrillation risk, in spite of LS size,
Much to be desired, and a lot of factors which we know contribute to stroke are not included in that risk score. Like dysfunction, all these also contribute.
So
to
that's why I mentioned that don't follow exactly guideline. You apply that what the need of the patient.
But we have to see what happens is that we are constrained in medicine to follow guidelines. Guidelines are not perfect; they can never be perfect, but we have to follow them, no doubt. And additionally, we can use our own thinking also. For example, what I see is that what I do is that if supposing Chad's is 2 or more, then we are supposed to give anticoagulation. At 0, we are not supposed to give. At 1 Chad's, it is supposed to be patient and physician's choice. So it's a class 2 indication. There I try to follow some other risk strategy. For example, there is a ABC risk
score is there.
So we look at other parameters and then decide whether patient, if there is LA enlargement, or if we find even like a factor like spontaneous echo contrast, which is just a precursor of thrombus, even that is not included in the Chad's. So if any of such things are present, then we obviously must, even at 1 Chad's, we must give anticoagulation. So at 2 or more, I definitely give. At 0, I don't give. But at 1, we look at other parameters.
Alok, you have some question?
Sir,
let sir answer first.
Sir, can I comment on Sir Saxena, sir? All this guideline TCG for evaluation of cardiovascular system. Honestly, I am speaking. How many of us we can calculate, as sir told, this Morris index left atrial overload from the ECG, 20 to 30%. So if we are telling,
तो बहुत simple है, क्या मुश्किल है?
so you no sir, what I am telling, so you go for the echo. So you what affordability? You reduce your fees. What is the problem?
Sensitivity and specificity of that index may be less.
ये तो बहुत standard teaching है, negative deflection of
No sir, what I am telling कि sensitivity कितनी है उसकी, ये मैं क्या कह रहा हूँ. 100 में 30 को ही पॉजिटिव आता है, 70 का क्या करेंगे?
नहीं, your point is well taken. आलोक बताइए, आलोक शर्मा.
सर अकॉर्डिंग टू मी, सर जो कह रहे थे वो पॉइंट बहुत वैलिड है. चैडवेस कोई मतलब का रहता नहीं है, क्योंकि सर उसमें इको क्राइटेरिया कहीं इन्वॉल्व ही नहीं किया उन्होंने. इको बहुत मैंडेटरी है. अगर एएफ का पेशेंट है, हाइपरटेंसिव है या नॉन वैल्वुलर एएफ है, तो आपको इको क्राइटेरिया उसमें इंक्लूड करना पड़ेगा. वो 0, 1, 2 के चक्कर में आदमी रह जाता है और काम बिगड़ जाता है. My question to you, sir, is your all the points are very well taken and very nice presentation. First of all, congratulations to you. Sir, question is, apart from controlling the hypertension adequately and giving all sort of anticoagulation well accepted, what are the subsets of patient where would you like to start SGLT2 inhibitor along with antihypertensives?
Thank you. In the complicated and when my patient is having the high risk, before to SGLT2 there is the era of ARNI and all this guideline of Asia, China and Asian country.
Be brief.
Yes. So this came ARNI already in the guideline for the coming to SGLT2. This is in the pipeline, but what we are getting for the systolic BP reduction is around 6 to 8, diastolic around 3 to 4 like this. So this is the pipeline and they are reducing the BP. So no way, and if your patient is having established HFpEF, that's the big elephant nowadays. So why not SGLT2? You use empagliflozin while treating the hypertension, use empagliflozin also to reduce the filling pressure, to reduce the LVS and so on and so. So there is syndrome of HFpEF with hypertension, use the SGLT2, that is well established in the domain. Yes.
Need your last question, you wanted to do something?
Michael Officer. Sir.
What is the difference in atrial fibrillation in these two? Any idea?
Yes. If you see this totally related with left atrial myopathy. If the isolated hypertensive patient with the diabetes and this patient also left atrial myopathy is more and more as compared to alone hypertensive patient. So we need combined to go both together. Fibrillation of atrial fibrillation and LA myopathy, what I was calling this increased filling pressure and LSI. This going to increase up to 30 to 35% if you combine hypertension and diabetes together, as compared to usual different literature different way, 20-25% in this hypertensive patient, because both is working on the same axis, doing the vascular problem, doing diastolic dysfunction. Early sir, जब आप मुझे डायबिटीज पढ़ाते थे तो यही कहते थे कि when we diagnose the diabetes 30% beta cell is lost. But right nowadays, what we are calling to diagnose the diabetes, already relaxation abnormality there and diastolic dysfunction is there, and you have some vascular problem. Beta cell तो होला सही, but this is established after doing the echocardiography. So that is stage 1 heart failure is stage A by ACC, just diastolic dysfunction and normal arterial diabetes. So this is the chances increase.
Basically, early stretch, gas activation, more with diabetes.
Thanks, Dr. Ansari, for such
Thank
an
you.
elaborate talk. It was a really learning point in this hypertension treatment. An arrhythmogenic concept.
And I request our respected person to kindly felicitate our speaker, Dr. Sajid
मैं रिक्वेस्ट करना चाहूँगा
Sajid Saab for delivering such a wonderful talk.
Rakesh? Rakesh Srivastava.
Yes, sir. आप लोग इस साइड है. Yes, sir. तो थोड़ा पास में ना. तो सामने देखिए.
सामने देख रहे हैं.
सर.
Thank you.
थैंक यू सर.
चलिए.
जी आइए. सामने देखिए मैम.
Dr. Sajid Saab, Advances in Management of Hepatitis B 2025. And
Yes, sir, सामने देखना.
Chairpersons, Professor R.C. Arora Saab,
सर हाथ.
Dr. Satish Agrawal Saab,
यस यहाँ देखना सर.
R.P. Singh sir, Dr. Saurabh Srivastava,
पहले आप सबको दे दो फिर एक साथ दिखाओ.
Dr. R.P.S. Kundela,
Yes,
Dr.
अब देखिए
Saidam
सामने, सामने देखिए.
to kindly take their respective seats to chair the session.
थैंक यू.